they may be asymptomatic for years, right? So heart failure comes from a million sources. You could have had an MI. So if you have a heart attack, you have an area of the heart that didn't have any blood flow for a period of time, and usually that tissue is now dead. So when you do an EKG, there will be wall motion abnormalities because that muscle doesn't work anymore. So anyone who's had a heart attack has heart failure because a section of the heart wall has died. Now they may not have symptoms for a decade, but they have heart failure. People are usually surprised to hear they have heart failure. They usually don't hear it until they're in the hospital in fluid overload and somebody says, oh, you have heart failure. I do? Yeah. So unfortunately, lots of people end up on hospice for heart failure because it is chronic, progressive, and irreversible. We can always slow it down by taking correct medications. We typically pay attention to the ejection of blood out of the ventricle, and it's called the ejection fraction. So what's a normal ejection fraction? What should the heart on average be squeezing out? What percentage? It's like a D on a grade. 65%, right? 65% is a normal ejection fraction. And so you'll see these on echo reports. So as you're learning in your field and you're seeing these things, start paying attention if there's an echo report to look at. You look at the ejection fraction. If they're at like 35%, that means they have bad heart failure. If they're at 40 or 50%, all right, they've got heart failure that's potentially symptomatic. So it's always good to pay attention to this because it kind of guides what treatments they get. All right, so these are the symptoms. So there's right-sided heart failure and left-sided heart failure, and it all makes sense anatomically. So depends on which side of the heart is pumping where your symptoms show up. So if it's left-sided, we tend to have pulmonary edema, cough, shortness of breath, and dyspnea. The right-sided is the one that tends to end up with pedal edema. People get congestion in their abdominal area, almost like ascites from liver failure, fluid in their abdomen, jugular venous distension. I don't know if you get taught that, looking at jugular venous distension. And this, hepatic congestion and ascites. So knowing which side of the heart, even though there's crossover, but for exam purposes, knowing right side versus left side, because at some point somebody's going to throw a scenario at you, and they'll either throw in that it's right-sided and you pick the symptoms, or left-sided, or they'll throw in the symptoms and you have to pick out which side it is. So just learning that. So what causes these structural changes? Well, we've already said a coronary heart disease, an MI. So when you have coronary artery disease, it often leads to cardiomyopathy. If you're not able to get a lot of oxygen through to the muscle of the heart works harder, the muscle gets thicker, which is not what you want. If you have bad valves, so either you have a stenosis, which blocks the outflow, or you have regurgitation, kind of a floppy valve, where it blocks the forward motion because it slides backwards. People with AFib, if you have a heart that's just beating like this all the time, it's like working out all the time. That muscle's getting bigger and bigger and thicker, and it's not as effective at pumping. People with pulmonary hypertension. So you know the difference between hypertension and pulmonary hypertension, right?
No.
So pulmonary hypertension can only be measured arterially. So people who have chronic lung disease, like a fibrosis, they end up with pulmonary hypertension, meaning that there is hypertension in the blood flow going to the lungs. And it's usually caused by some sort of lung disease that's making resistance against the blood flow. So if you have resistance to the blood flowing into the lungs, you start to build up pressure and you get pulmonary hypertension. And that gets treated sometimes in a different way than regular hypertension. And then people can just be born with crazy heart structures. That's just the way it is. Anything else that causes the heart to work too hard? So anytime you're making the heart work for long, long periods of time, you can end up with heart failure. So if you are chronically anemic, if you are someone who's dehydrated all the time, hyperthyroid, if you've got infection, diabetes is a huge contributor to cardiovascular disease. Most diabetics don't know that. So drug therapy. Here's my little key. All the things you should know by now, what an inotrope, chronotrope, and dromotrope are. You don't need to know bathmotrope. That is beyond the scope of this course. So these are all the drugs, and it looks like a lot, but there are some that are more important to know than others. So some of them you've seen them before: ACE inhibitors, angiotensin receptor blockers, beta blockers. So those are the ones we've covered before. Did we do the PDIs? Probably not. Diuretics are coming up, cardiac glycoside. The really only important drug, it's missing, there's supposed to be another line, is digoxin. This is another one here, aldosterone antagonist, angiotensin receptor. These are new classes of drugs, sort of all these three here. So the ones that you really should know: ACE, ARBs, beta blockers, this one, diuretics, cardiac glycosides. Those are the main ones, and you already know 3 of them, so you're halfway there. So early on, the drugs that get used are to reduce the effects of the renin-angiotensin-aldosterone system. We're trying to interfere with the vasoconstriction that's causing a lot of afterload for the heart to work against. So we know ACE inhibitors, ramipril, lisinopril, and allopril, ARBs, ALID, and Artan. You should know that by now. Beta blockers, OLOLs, cardioselective beta blockers. So that's just a review. It's my favorite. When you check to see if it's time to take your drug, I mean, that's some pretty good edema going on there. Yeah. We start to add on loop diuretics, mostly to reduce the symptoms, where the other drugs were trying to block some of the pathophysiology that's happening, the aldosterone release. We're trying to prevent that whole renin-angiotensin-aldosterone system, which is now a little bit out of whack. We're trying to inhibit it. We're loop diuretics. So furosemide, torsemide, bumetanide, you can see what they all have in common. Amide, anide. We're treating just the symptoms. We're forcing the body to diurese and get rid of extra fluid, extra volume. And that's because the heart is not a good pump anymore. You've got this really crappy pump, and it's not able to pump efficiently to get fluid to your kidneys so you can filter it and urinate. So we have to add on something that just is going to force the urine, force the fluid into your urine and out your body. These get added on as the heart failure progresses, so they directly inhibit aldosterone. Sometimes they're called potassium-sparing diuretics, but they actually fall into the class of aldosterone inhibitors. So if you see spironolactone and eplerenone, know their mechanism of action is to inhibit aldosterone, renin-angiotensin aldosterone, and that they do this. And so loop diuretics, you tend to have low potassium. These ones hold on to potassium. And if you see this get added on, so a patient has an ACE inhibitor, a beta blocker, a loop diuretic, and now they're adding one spironolactone or eplerenone on, you can know this person has advanced heart failure. Because when we start adding this on, the person's down the slippery slope. And only after these drugs do we start adding on digoxin. And it falls into this class of cardiac glycoside. We also use digoxin for heart rate rhythm issues, but it's not the first choice because digoxin's like phenytoin. It's got so many things about it you have to watch, and it's got a narrow therapeutic window, and labs you have to be careful about, and drug interactions. So we're not a big fan of them. This is particularly one they ask you to know because it's the first drug approved for which specific ethnic group? So, which specific ethnic group? Blacks. So this is the first choice in heart failure for people of black ethnicity. So we use hydralazine with an isosorbide. Hydralazine is a, isosorbide is a,
Go back in my notes.
you'll have to figure out what it is. So it comes in this combo drug, Bidil, hydralazine isosorbide, that was approved specifically for, they're just genetically more effective in the African American or black population.
Is
that one of the calcium channel blockers?
the top one's a calcium channel blocker.
The other
I can't remember what the top
diuretic
Yeah.
has to be a
Right, so calcium channel blockers aren't usually first line, except in this population. So that's one of those things they always throw out it's the one ethnicity that gets thrown out for a drug difference, is that we tend to go through to like a calcium channel blocker before we would go to an ACE inhibitor, because they respond better.
Oh, okay, they do better in
Yeah,
those. Okay.
it's just how they metabolize for whatever reason. All right, so ACE inhibitors, it's the pril family. This is the coat of arms for all the prils, lisinopril, enalapril, you know. They prevent sodium and water reabsorption, and so just knowing what you recognize, we already went over all this. I'm not going to beat a dead horse. Angiotensin II receptor blockers all end in artan. So losartan, valsartan, candesartan, that's how you can recognize it. This is sort of the mechanism of action here. We use it alone or in combination with other drugs for heart failure. The only caveat is we never use which two drugs together? An ACE and what? We don't use an ACE and an ARB together, ever. Because they are basically in the same, interfering with the same cycle. So we never, if we see somebody that's discharged on lisinopril and losartan, you're going to be like, whoa, okay, stop. We don't do that, ever. There's no exceptions. So the angiotensin receptor blockers are less likely to have the cough, are less likely to cause hyperkalemia. Doesn't mean it doesn't happen, but it's less likely. That's why sometimes we switch to them. Oh, here's a joke. What's the pirate's favorite treatment for hypertension? Arbs. You'll never forget now. All right, I've already talked about beta blockers and why they're used in heart failure. So after an MI, you automatically have heart damage. We have those floating high levels of catecholamines. That tamps that down. We also want to reduce the heart rate, so we have better filling. And we tend to use the cardio-specific beta blockers. What's the general class contraindication for beta blockers? Who don't we give them to according to the book?
Asthmatic?
Asthmatics, right? This aldosterone antagonist, this one, I didn't even write the drug. That's funny. Let's skip it. No, there it is. I wrote it on the next one. Okay, so we said when you get to this class, the potassium-sparing diuretics or aldosterone antagonists, we know they're in advanced heart failure. So these are the two we typically see, spironolactone and eplerenone. They do tend to elevate potassium, especially if they're taken with an ACE or an ARB. Yeah, so all the learning is on that slide. Just recognize the name ivabradine. You don't have to know a whole lot about it other than, it falls into this class of sinoatrial node modulator, just meaning it's dealing with the electrical flow between the SA and the AV node. That's its mechanism of action. We use it for people with really bad advanced heart failure. And the key is avoiding grapefruit. That's like a gimme question. If you see ivabradine, if the only thing that sticks in your head is heart failure and grape juice, grapefruit juice, not grape juice, grapefruit juice, you're good to go. There's phosphodiesterase inhibitors, so classified as inodilators because they're inotropics. What's an inotropic? Increases the
contraction.
Heart rate.
force of the contraction, and a dilator. So you get two for the price of one. Positive inotropic, so increased squeeze, and then vasodilation. We like those. This is the one you're going to get tested on, milrinone, which is an inpatient drug. It's an IV drug. It's used for heart failure in the ICU. There were questions on the next gen case study about it. So what was the key about how you administer it? So if you have multiple drugs you need to administer, what's the key about milrinone?
Needs its own.
Needs its own line because it will precipitate if it's given with other drugs. Yeah. And let's see if there's anything else you need to know about that. Cardiac dysrhythmias, thrombocytopenia. Oh, and the labs you need to watch. So there's a propensity for thrombocytopenia, which is low what?
Thrombus.
No.
Platelets?
Low platelets. So that's a CBC. Elevated liver enzymes. So what lab test is that?
EST.
LFTs, liver function test. So that has a whole panel of it. And then potassium problems. So with these patients, you'll be getting a CBC and probably a Chem 14 because a Chem 14 includes the liver enzymes. Otherwise, just a chemistry and an LFT, but that's a Chem 14. So loop diuretics, their mechanism of action is to reabsorb sodium at the loop of Henle. So we have sodium going into our urine. Wherever sodium goes, water goes. They are kind of like husband and wife. Where one goes, the other goes. And so if we are telling our loop of Henle to absorb sodium, then all of the water passes into your urine where you pee it out. So remember, they are to reduce symptoms only. They don't change the disease course. And a key in teaching it is sometimes people are given twice a day dosing. Please do not have them leave your presence before you tell them the second dose is not in the PM. Otherwise, they'll be up peeing all night. This is a powerful diuretic. Loop diuretics are the strongest. That's what they give, usually IV, in the hospital for fluid overload because it works so well. So if somebody's on it twice a day, they should take it first thing in the morning and then maybe 4 to 6 hours later, not AM and PM. Otherwise, they have a miserable night. So this is the cardiac glycoside. It's the really old drug, digoxin. We call it a dirty drug, and that's kind of a slang term, so it's a little dirty guy, because it has so many drug interactions. It has a narrow therapeutic index. We do use it at times in heart failure and to control the rate with AFib and A-flutter. We don't use it also because it hasn't been shown to reduce mortality in heart failure like beta blockers did. So that's why it's not first line. If it's not going to change the outcome for the patient, we should use the drug that will change the outcome. So this is sort of like the little overview teaching. Here it is. How fascinating that it came from foxgloves. This is the mechanism of action. These are the side effects. The ones they ask you about usually are visual disturbance, and they classify it like seeing halos or green lights. And I don't know anybody who ever had that, but usually they have nausea and vomiting. But that's like a test question they'll say. And the patient's complaining of, I see funny green lights in front of my eyes. Yeah, just know that that's potentially toxicity from digoxin. Let's see. So here's the goal of heart failure: improve symptom control, improve quality of life, improve exercise tolerance, and their ability to perform ADLs. It's very similar to like seizure control. Really, you're not getting rid of the disease. You're just trying to maintain a good quality, good function. What do you need to know about digoxin? So you should know the therapeutic window, because for sure they're going to throw out a lab value and say, what do you need to know? You need to know that you have to watch electrolytes because low potassium makes it more toxic. What it's used for, resistant AFib and A-flutter, among others. And then all of the biggest one with digoxin is that fiber binds it up. And they typically focus on high fiber foods, but the problem is people take fiber supplements as well. And then there are some lipid medications, the anti-lipemics, of the bile sequestering drugs that are fiber, and fiber binds with digoxin. So if somebody is taking Citracel fiber every morning, you don't want them to wash down their digoxin with that, because basically you've inactivated half the medication. So that's patient teaching about avoiding high fiber foods, fiber supplements, fiber, and you have to think like a nurse. And what else could they be doing that's fiber, you know?
What is the measurement there? They're ng.
Nanogram per milliliter.
Oh, nanogram. Never heard that one.
Super small.
Uh-huh.
What else do you need to know? Side effects can be seizures. This is the one that they ask you about, seeing halos, seeing green, yellow, flickering lights. I've seen more nausea, vomiting with digoxin toxicity. All right, a patient's in the ED with new onset AFib. Which order for digoxin would most likely have the fastest therapeutic effect? Yeah, which one?
The one that says now? New one?
That's a good key, the one that says now. Give 1 milligram IV push now. Yeah, kind of tricking you. So there's terminology called the digitalizing dose. That first dose is to rapidly increase to a therapeutic level that digoxin. So they give a digitalizing dose to immediately, and then their daily dose to maintain that. And meanwhile, you're drawing labs and all of that good stuff. So know your therapeutic value, know about a digitalizing dose. Lots of things can cause you to have digoxin toxicity. We already said low potassium. It's the opposite with calcium, and I saw this on a different test. I can't remember, maybe it was last term, where there was high potassium and high calcium, and people got confused, and they thought it was low potassium. It is low potassium, but it's high calcium. So, and that simply has to do with, if you remember that little picture over here, it's a calcium channel that's being affected. And all of these, and of course being old. Here's the antidote. Digibind. Makes sense. You're binding up the digoxin, right? I like the name, Digibind. It's fab. Question 2. Patient is getting digoxin, 0.25 milligrams per day as part of treatment for heart failure. The nurse assesses the patient before med administration. Which assessment finding would be of most concern?
C.
So, okay, so what's normal potassium levels?
3.5.
3.5 to
All right.
5.
And so if you immediately already learned the digoxin level, 0.5 to 2 nanograms per milliliter, so 0.8 is therapeutic. So they were trying to trick you right there.
So what's the third thing? So 0.5 to 1?
2.
0.5 to 2 per day.
It's in the slide, so, and it's in your book. 0.5 to 2 nanograms per milliliter. And your lab should come out in that measurement value because it's so small. And so, yeah, the apical pulse is slightly under 60, but we know with digoxin that it, so if we use it for AFib and A-flutter, which are rapid heart rates, we know that it has a propensity to slow the heart rate. So yeah, it slowed it a little bit, but it's nothing 56. It's not the most concerning issue. The most concerning issue, like John said, was the potassium. Ankle edema, it's not necessarily new. We don't know if it is, we don't know. And then the digoxin was in the therapeutic range. Wow, that was good. And the other one they like you to know, dobutamine, is used in critical care support. It's by IV. It's kind of similar to dopamine. It's a beta-1 selective adrenergic drug, positive inotrope. So we give it for short-term treatment when people have decompensated heart failure and their heart muscle's really weak. We're trying to get some squeeze out of that heart. Here are your or your things that you should know. Anyone who has heart failure with any sort of rhythm issue or anything No, that's this one. You should always never ever be using a wrist cuff. If I ever catch one of you using a wrist cuff, I will haunt you in my grave. Wrist cuffs are well studied and known to be inaccurate. And they can be really inaccurate. So a nurse should never be using a wrist cuff. I will pull your license.
We haven't get it.
Anyone who has an arrhythmia, right, you should be doing an apical pulse for a full minute. You cannot just have the machine on them and look at that and say that's the pulse. You have to auscultate and count for a full minute, because that machine is actually taking a segment of time and multiplying it by a number. It's measuring for 6 seconds and multiplying by 10, or 10 seconds and multiplying by 6. It is not getting every single beat. You've got to listen. And nurses do this wrong all the time, and it's critical because it makes the difference in drug dosing. I mean, if you don't do that, somebody dies. You want to check heart sounds, breath sounds. Yeah, these are all the things in the labs. All of the electrolytes. We don't need none of that. So that was the teaching, weigh every day, all of the things. What's PND? So symptoms of heart failure. Someone with heart failure and fluid overload may have PND. Paroxysmal nocturnal dyspnea. What is it? Dyspnea when they lay flat. When they lay flat, because there's a lot of sometimes pulmonary congestion in there. Now you're laying flat. When you're upright, all of that pulmonary congestion is pulled downwards. When you lay flat, you have it all sort of floating against your lungs. And people often end up being recliner sleepers because they can breathe better sitting up. And they never tell anyone that they sleep in a recliner because they can't breathe laying flat. And that's called paroxysmal nocturnal dyspnea. Patient with a history of heart failure comes to the ED with difficulty breathing, cough, and edema of the lower extremities. The nurse anticipates administration of what type of medication? Ooh. That's a hard one. So we're going to increase the speed of the heart rate, decrease the speed of the heart rate, increase the force of the contraction, decrease the force of the contraction. What might you expect? Let's see what we got. Yeah. Somebody in heart failure has a problem with the function of the heart, and fluid is going places because the pump is not working well. So they told you that in the beginning. He has difficulty breathing because he has pulmonary congestion that manifests as difficulty breathing and cough, and he has other physical manifestations of fluid overload. So that means his pump is not working well. You can expect that they will give him something that will help the pump squeeze harder. So yeah, you would expect a positive inotrope. Whoever said that, 10 points on your next exam.
It was me, I said it.
All right, the patient.
You're very generous today.
I know, and patient is prescribed an ACE inhibitor. The primary mechanism of ACE inhibitors. What primary mechanism of ACE inhibitors will the nurse understand as the therapeutic action? So an ACE inhibitor.
See, it's gonna stop. It stops angiotensin too from being angiotensin 1 to 2. So, yes.
Yeah. If you just can think, if you memorize nothing, memorize the renin-angiotensin-aldosterone system, because that solves a lot of your problems of where the drug is acting. So yeah, because they're acting to inhibit aldosterone secretion. If you inhibit aldosterone secretion, then you prevent sodium and thereby water from being reabsorbed into the bloodstream. So you've lowered the fluid volume, you've lowered the afterload of the heart, you've lowered the preload of the heart. Yeah, you've done a great job. Nurse will monitor which lab results during, patient does. The patient does. Patient is not responding well to current medication therapy and is started on a milrinone infusion. Remember we saw milrinone, we saw it in a slide, and it was on the next gen. The nurse will monitor which laboratory results during this infusion. Select all that apply. There are 3 key things with milrinone.
Potassium, platelets, and liver.
The potassium, platelets, and liver, yep. That's what it was. Well, they threw it in all, but the key is potassium, platelets, and liver. If you have end-stage renal disease, okay, yeah, I guess we should watch our kidney function, but it's basically the potassium, liver, enzyme, thrombocytopenia. All right, now you know that.
Now it's time to go home.
No, there is so much to learn. We'll do one last fascinating thing. We'll talk about the dysrhythmics and try and make it, let's see. So everybody is familiar with all this basic function of the right. Where does the electrical impulse start? SA node. All right, so this is our little generator right here. What's the next step? AV node. Then where does it go?
Bundle of his.
Okay, you got it. Bundle branches, Purkinje fibers. And it's pretty logical. So you have atrial contraction, ventricular contraction. And it needs to be in that order. When it's not in that order, things get screwed up. I mean, we were made that way for a reason. So you can get a dysrhythmia. Okay, so we all say arrhythmia, but arrhythmia technically means without a rhythm, right? It means you're dead. You're asystole. So the correct term is dysrhythmia, meaning wacko rhythm, but I still say arrhythmia sometimes, so please excuse me if I do. So, so after a heart attack, surgery, coronary artery disease, congenital, we use antidysrhythmics to treat and prevent all of these cardiac rhythms. So knowing why they happen, anyone who has a heart attack can end up with some sort of dysrhythmia, because wherever the wall died, now you have dead nerve cells. You don't need to know all of the rhythms. That's way beyond the scope. Most of the drugs target these sodium channels, either speeding up something or delaying something. So we use antidysrhythmics in AFib and A-flutter, VFib and VTAC. What do you know about VFib and VTAC?
Usually the ones that kill.
Yeah, ventricular dysrhythmias are the ones that kill. Lots and lots of people are running around with AFib and never know it, unless their smartwatch just told them. But if you have VFib, you are in an emergency room and it's a big deal. Yeah, those are the deadly. So anytime you see a ventricular dysrhythmia, know that there's going to be some hardcore drug associated with treating it. PVCs, meaning the ventricle starts contracting before it should. So that's not good, because if it starts contracting at the same time as the atria contract, when the atria contract, then the valve opens. Well, what happens if the ventricle contracts at the same time? Like, you have no forward movement of blood. It's a little bit inconsistent with health. Then you have paroxysmal supraventricular tachycardia, a great big word, meaning that you have some other pacemaker cells firing, telling the ventricles to go. So you have the SA node and the AV node, and then some random other cells saying, go, go! And so the ventricle's contracting at random times. And then different times of block, different types of heart block. All right, so they are categorized as to where and how they affect cardiac cells. The main thing you should always remember about any antidysrhythmic medication is that they can cause dysrhythmias. So you might be trying to treat something and you end up with something worse. That's the game we play. It's Russian roulette. You'll see this term pop up as a contraindication in a lot of meds. This is Wolff-Parkinson-White syndrome. So this is the normal, we said the normal pathway, SA to AV node. So people with Wolff-Parkinson-White or WPW have an accessory pathway or a bypass tract, and so it throws off the sequence of contractions. They may have a pathway here instead of going this way. So they may not even get an atrial contraction and get a ventricular contraction. And then this one will fire and they'll get an atrial contraction. They have a whole separate, they have the correct wiring system and then an accessory wiring system that's bypassing where it should go. So that can't be consistent with good health, I would say. So you'll see that some things are either indicated for Wolff-Parkinson-White syndrome or contraindicated. So you don't need to know the class of the drug, just recognizing, okay, so there's two biggies in this class, procainamide and quinidine, that fall into this first class of antidysrhythmics. They are used for some of the more problematic rhythm issues. So anything that says tachydysrhythmia means it's a fast dysrhythmia, right? Tachy means fast. So we use it for inpatient typically for acute issues. Problem is, yep, it can cause ventricular dysrhythmias. Then learning that procainamide is associated with blood disorders and low white blood cells, some lupus-like syndrome, and then again this QT prolongation. And you shouldn't take it if you have lupus. So what is QT prolongation? So QT, if you remember, let's see, what have you learned about the basics of a cardiac cycle? So the QT interval is the time between when the ventricles have closed and the heart's recharging. And so there is a certain interval of time which is normal. But when you start to prolong this time with drugs that do it, or you are already born that way, or you're taking multiple drugs that prolong this particular interval, if you saw it on an EKG, it starts to cause a really weird turning spike. And that's called, it's a French term, torsade de pointe. People just call it torsade. So it's an uncommon form of ventricular tachycardia associated with this prolonged QT interval that can be potentially deadly. And so that's why we're careful with this particular drug and lots of drugs, this particular class, procainamide and quinidine, because they have the potential to prolong this QT interval, which can lead to a life-threatening dysrhythmia. So you'll be getting an EKG frequently on a patient who's on this drug because they're watching that QT interval.
Would it be on a television then?
Yeah, they would. And then quinidine, yeah, same general thing, although it does have some anticholinergic effects. It does have a significant adverse effect. I'd say that's pretty significant. Your heart stops. That's a pretty significant adverse effect from quinidine. They throw out this terminology here, and I think I saw this on a template for a HESI or something, this synchonism. And that is the stupidest term ever. It's related to cinchona, which is an alkaloid plant or something. This is the grouping of symptoms: ringing in the ears, loss of hearing, blurry vision, and GI upset. So quinidine is associated with this synchonism, if you learn nothing else, and it can cause torsade. A lot of information in a couple of slides. This second class is still under the umbrella of, like we were saying, there's adrenergic antihypertensives, and then there's all different kinds. This is class 1, and there's a bunch of different kinds under it. Again, they're all acting on sodium channels. Lidocaine and phenytoin. So what was phenytoin? Yeah, anti-epileptic drug. So we're using an anti-epileptic drug. What's lidocaine fall into?
Anesthesia.
Yeah, so we're using drugs in a different way. You've learned about the drugs, however, these ones we're giving IV. So that's one reason that people who are doing lidocaine, we don't want them to get too much lidocaine, because even if you're putting lidocaine on your skin, you get a little bit of systemic absorption. So you don't want people, spreading their entire body with lidocaine, because they can end up with having issues systemically. So lidocaine is used for these ventricular dysrhythmias we talked about, and phenytoin is used for digitalis toxicity, so digoxin toxicity, and if you have long QT syndrome, meaning you have this really long interval. These are the adverse effects. I don't think you need to know. Heart block is basically it, if you have got heart block. This one, let's see if you need to know anything about, flecainide. It's only inpatient. This is used for life-threatening sustained ventricular tachycardia. So remember, right, we said that the ventricular dysrhythmias are the most deadly. So if somebody has a ventricular issue, they're going to be in an ER. Yeah, you can expect that this will be given for the heart issue because it is acting more on the ventricles in order to slow them down. It's a negative inotrope. So less squeeze there, lots of adverse effects, but these people are usually lying down. They're never going to know if they're dizzy or not. So recognize that flecainide is used for like VTAC. This is class 2. You've seen these before. We use beta blockers for rhythm issues. We know why. We know their function because of what they do in the sympathetic nervous system. So we're not going to beat that dead horse. We use the cardioselective ones, like atenolol. So the thing, I remember going over this before when we were doing the beta blockers. Some of them have one effect at a lower dose and a different effect at a higher dose. Remember kind of briefly mentioning that? So at a lower dose, they block the beta-1 receptors, but at higher doses, they become non-selective. And it's just the way it is. When in reality, we know that there's crossover. At the lower dose, there's crossover, but there's not enough to see that effect. When we start giving large doses, that's when we're seeing enough of that crossover to see that vasoconstriction. All right, so, and esmolol, they'd like you to know, it's super short acting. It's used for acute treatment. So this is all of these are inpatient. Well, atenolol is not necessarily inpatient, but esmolol might be used inpatient for tachydysrhythmias after an MI. This is how you memorize the cardioselective beta blockers by learning about man babes. I make that one up, but that's one way to learn them. I mean, these ones you should already, metoprolol, atenolol, nebivolol, esmolol, big ones. Well, metoprolol, we said already, talked about why, blocking catecholamines. Class 3 is used to stabilize the cardiac cell membrane. It's used for difficult to treat rhythms. And so most of these other ones treated rate. So basically we're just slowing down the heart rate. This class of drug is used for rhythm control. It's something different. So if you see somebody on a rhythm control drug, they've got a really whacked out electrical system in their heart. It's for a really resistant AFib, a flutter, that they've been cardioverted, they're on all the appropriate medications, and they still have AFib, a flutter. Then we're going to go to some of these hardcore drugs. So the big one is amiodarone. So amiodarone usually is prescribed by a cardiologist. You won't see it in primary care. It's alpha-beta receptor is one of the most effective ones for it, but there are lots of side effects that patients never get told about. One is corneal microdeposits. So they can get a buildup of microdeposits on their cornea that impairs their vision. They are at risk for a more serious optic neuropathy. So these people need routine eye exams. This is a known side effect of long-term amiodarone use, pulmonary fibrosis. They have to have an annual chest x-ray because it does happen with long-term use. So your job is to make sure that your patient knows when they leave a hospital on amiodarone that they will be needing a routine eye exam and they will be needing annual x-rays because the drug affects the eyes and can give you, you can just say fibrous lungs, like a dry sponge. It's very hard to pump through, it's hard to breathe through. And then the big drug interactions. Amiodarone is I've got bad words for it. In effect, it interacts with so many things, including digoxin and warfarin. So most people who have an arrhythmia like AFib are on an anticoagulant. Well, that's great. This interacts with an anticoagulant. This was used for heart rhythm issues. This is used for heart rhythm issues. Great, we have an interaction with all of them. There's not a good answer. This is the other option that you'll see people on, dofetilide. So amiodarone was the first one, dofetilide is the second one. These people have to have extra special training. This has to be started inpatient, and they have to have continuous ECG or EKG monitoring for the first 3 days. So those are the main things to know about these two drugs. These are like big deal drugs. Sotalol, you'll see, it's a beta blocker. It falls in this class. Even though it's a beta blocker, it's not with the other beta blockers, but it does fall in this class. So if you see it, you'll know why. Then the other class is calcium channel blockers. So a lot of them, you know, beta blockers, calcium channel blockers. And that's how it acts. Diltiazem, this is where we see dihydropyridine or non-dihydropyridine? Non, right? Dihydropyramine, they dilate. They end in INE. The non-dihydropyramines are the ones with the weird endings, diltiazem and verapamil. They are used more for rhythm issues. So if you see those drugs, you'll know probably why they're on it. This is just the other one. Both of them are there. Here's an unclassified one, and they love to throw a question about this. So adenosine. It's used to convert this paroxysmal supraventricular tachycardia, this crazy electrical impulse that's coming out of nowhere to convert them back into a sinus rhythm. Look how short the half-life is.
Oh, goodness.
It's only given as a fast IV push, and the expected action is that it does cause asystole for a few seconds.
So it like stops the rhythm.
Patient
so you
flatlines for a few seconds, and then the heart goes again. That is the expected reaction.
So it's a reset button.
Isn't it? Isn't that scary if you're the nurse and your patient like, shit, they just flatlined. And then it starts going again. Oh, I gave adenosine. That's what's supposed to happen. All right. Phew. I didn't kill them.
Cool.
So why would you give that to
It is a reset.
Because we're trying to convert them back into a sinus rhythm.
So literally like a
It's
reset
literally
button.
like a reset. Yeah. Isn't that cool? Like we just like stop their heart and then they get to go
This
away.
box doesn't work, turn it off.
All right. When I bring propranolol, I'll bring some adenosine and we'll tie it out on you.
Yeah, let's do it.
What was that movie that they would kill each other? They were like medicine students. They would kill each other for just a few seconds.
I don't know.
And
I
then they would
must
go
have missed
into this, you know.
And one time, 20 minutes, yeah.
I don't
It was
know.
several years ago.
that. I don't know that
It's
movie.
an old movie.
Yeah, old movie.
So there's lots and lots of contraindications to all of these drugs, and a lot of them are very specific to the drug. So really, you have to see the drug and look it up, basically. I mean, there are some basic things you should know about amiodarone and beta blockers and calcium channel blockers, but knowing that all antidysrhythmics can cause dysrhythmias. The biggies. Drug interactions, Coumadin and grapefruit juice. Woo woo! Yeah. Patient has received an IV dose of adenosine and almost immediately the heart monitor shows asystole. What should the nurse do next? Yeah, that's the scary one, right? They're dead? No, they're alive.
So what
Set
happens
the
if they don't come
defibrillation.
back?
Continue to
They don't come back. You check their code status and you call a code.
Oh, wow.
So yeah, it's just,
But do you literally only wait 10 seconds? Like 11 seconds, do you?
I mean, I would say that's a judgment call.
No. But if it's like 20, 25
Yeah.
seconds, I'd be
I think
like,
if you get to 30
okay, now it's time.
seconds, you're still asystole, I'd say go ahead and call it.
It's 30 minutes. Just
Yes. It's just continue to monitor because it should only last for a few seconds.
that's crazy.
Oh, yeah, that's one you'll never forget. Patients in the ED with an unspecified supraventricular dysrhythmia. The provider orders a dose of diltiazem, IV push, While the nurse administers the medication through the IV lock, the patient says she feels something wet spilling on her arm. Her heart rate was unchanged. What will the nurse do next?
Check ID.
Yeah, check those.
All right, we got some nurses in here. Check your IV, right? It's not a sensation that comes from the drug like, oh, I feel like my arm is wet. No, it's actually your IV leaking. You're in your drug book looking that up.
What would cause your arm to feel wet?
Patients
Googling it.
A veces
wet arm sensation.
Wet
Yeah.
arm. All the facts thing.
Patients getting oral quinidine. Which assessment finding is of most concern? Yeah, it's the prolonged QT. That's in the class where we're watching this prolonged QT. So they need to be monitored. Yeah, that's the QRS. So QT interval. All right, that's it for today.
Now we can go home.
That was a lot. I expect you all to know it by Thursday. Because you've got what?
Cute.
We will.